Then which ligament is important for preventing the prolapse, doctor? Cardinal is the one. A female has got amenorrhea with elevated FSH. Who will inhibit the FSH secretion, doctor? It is the ovarian hormones which will inhibit. In a case of the Turner syndrome, when there is a ovarian dysgenesis, when the ovarian hormones are not produced, nobody to inhibit the FSH and LH. So there's a reason their gonadotropin levels become elevated. So there's a reason, doctor, to know whether a given case of the gonadal failure is primarily because of the gonads or because of the pituitary. Check the FSH. If it is elevated, then the problem is with the ovaries. If it is decreased, then the problem is with the pituitary, is what you can be able to conclude. What is the most common cause for the development of the vesicovaginal fistula in this part of the country? It is the neglected labor, which is very, very important. Corkscrew shaped endometrial glands, where do you come across? Different appearances of the vaginal cytology and the menstrual phase. This is one of the favorite questions of the examiner. So please remember, doctor, in the late secretory phase, typically the lumina of the endometrial glands become filled with the secretions leading to the corkscrew shape is what need to be remembered. So this gives you the high magnification of the uterine glands during the secretory phase. So the spiral nature in the corkscrew shape is unmistakable. This gives a little higher, lower magnification, where you can see, better appreciate the presence of this numerous elongated stretching appearance of the endometrial glands, which has got a corkscrew shape. Now let's go to the next question. If you have done the, yes? So that's the reason late secretory phase becomes the answer, rather than early secretory phase. Okay. Now failure of sterilization surgery, if you carry it out at the time of cesarean, what is the cause? I'm not very sure, so if I'm not sure, let me not present it. But if you get an answer, please give me with a proper reference. It is appreciated. Early absorption of suture. Okay. But in the case of sterilization, is it absorbable or non-absorbable, which is used, doctor? There is another important question. Please check it. So certainly when we don't know, we do more mistakes. So I like to get a reference, I would appreciate. Let's go to the next question. Endometrial carcinoma is associated with obesity, granulosa cell tumor and the endometrial hyperplasia. All this can predispose. That's the reason those who are having a lot of exposure to the estrogens, there can be endometrial hyperplasia, which can lead to adenomatous changes leading to the carcinoma. Is there anything like endometriosis and carcinoma? Not associated. Now let us go to the next question. Dystocia dystrophia syndrome typically seen with the android pelvis. So different pelvis, we'll have a more extensive discussion in the obstetrics. I'll try to run off because of shortage of time. Parabasal and the basal cells, where do you come across, doctor? Typically in the postmenopausal phase, when there is an atrophy, at that point of time when there is a menopausal atrophy, this kind of large sheets of the parabasal and the basal cells is a classical feature in the vaginal histology, cytology is what need to be remembered. Now once more, where do you find early deceleration, variable deceleration? So remember, cord compression leads to variable deceleration. Head compression leads to early deceleration, should not be basically forgotten. Okay. So let's go to the next question. That is probably past 7 years. When we used to write the entrance, that time onwards is a standard question. Any entrance you go means one compression and one deceleration must invariably be there. So that's the reason stock paper, don't worry. Which IUD is important in menorrhagia, doctor? Typically a hormone-laden progestastat which has got levonorgestrel causes less amount of menorrhagia compared to that of the other IUD types. Now this is a challenging question. SLE patient with recurrent abortions, what is that syndrome called? Antiphospholipid antibody syndrome. How do you want to manage? Earlier question? This question? Yeah. During pregnancy was also given. Okay, no problem. We'll manage that case also. Because in MD, my thesis was antiphospholipid antibody syndrome. At least some 250 cases were treated. So that's the reason I have seen pregnant women with a catastrophic antiphospholipid antibody syndrome. What is catastrophic, doctor? If more than 3 organ systems develop the thrombosis and complications. What are the various areas thrombosis can occur in antiphospholipid antibody syndrome? There can be development of the CSVT, there can be a Budd-Chiari syndrome with the hepatic vein thrombosis, there can be a DVT, and there can be a recurrent abortions everywhere, multiple areas, there can be stroke episodes. So young individual of about 25 years, 30 years, stroke at young, you have to evaluate, especially in females, the possibility of anti-phospholipid antibody positivity. Now the question is, how do you manage it? Fundamentally, these individuals need to be anticoagulated. Lifetime anticoagulation, not 1 day or 2 days. I still remember one of my patients, she was suffering from infertility because of the recurrent abortions she was having, and she already has developed DVT and she was placed on anticoagulant therapy. After going to home, somebody said, in the Zems Institute unnecessarily they have started it, that is the reason for your infertility. Poor girl already was frustrated that infertility was a major problem. So she stopped taking the anticoagulants because of the myth which was induced by her in-laws and everybody, and she has landed suddenly with a stroke. So the problem of infertility is a stupid and simple problem, because but the stroke is much more a catastrophic problem. So in spite of explaining to the patient that anticoagulation is required for a lifetime, sometimes patients will not be compliant. But our duty is to continue to explain the patient is the golden rule which you should not forget. Your patient doesn't stop smoking, still you must talk about anti-smoking until he continues to be your patient. So that's the reason, doctor, you need to anticoagulate. Now the question is, one injection of heparin low molecular weight will be costing nearly about 350 to 400 rupees. Can you give that Lomorin, low molecular weight heparin to the patient throughout the pregnancy, which is for about 300 days? It will be the costliest pregnancy any woman can ever have. So that's the reason, doctor, what to do. If you give warfarin, then the fetal embryopathy will be developing. So then International Association Against this thrombotic disorders have given a protocol. In the first trimester of pregnancy, maintain her on a low molecular weight heparin, and after that you continue on warfarin, and before delivery, once more in the last couple of weeks before the expected date of delivery, convert back into the low molecular weight heparin is considered with the protocol. So there's a reason, doctor. Anyway, examiner did not mention which trimester she is in, so you can still try the examiner on this important fact. So warfarin becomes absolutely the choice in this given case, but in the first trimester, no doubt, no warfarin please. And in fact, while you are giving warfarin, you must check if she is having, you must advise her about, if she is planning the family, then you need to advise her about this important embryopathy as a complication. Now my question to all of you is, doctor, if you want to start warfarin, can you simply straight away start like that? Or before doing that, what is a very important precaution? First 3 days of the warfarin must be clubbed with low molecular weight heparin any time. What is the reason for that? Warfarin basically will lead to vitamin K deficiency. Now what are the vitamin K dependent factors? 2, 7, 9, 10, and protein C and protein S also are vitamin K dependent. So protein C and protein S, basically what are they, doctor? They are generally anticoagulant. If the levels fall, there is a procoagulant tendency. But out of these all factors which are vitamin K dependent, the first to fall is not the anticoagulant factors. I mean, it is not 2, 7, 9, 10 which will fall. It is the first to fall is not the coagulant factors. It is the anticoagulants which will first fall. So protein C and protein S will fall first. So that is the reason, doctor, if you start only warfarin, first 3-4 days, because protein C, protein S will fall down, there is a tendency for procoagulation, hence there can be a skin necrosis which can develop as a complication. There is a reason first 3 days to take care of that procoagulant tendency, because the fall of the protein C and protein S, one of the important protocol while you are writing the prescription of the warfarin to the patient is first 3 days he must take the what is called as heparin along with, and later on he can take lifelong the warfarin, but he need to check his INR values. In the case of the antiphospholipid antibody syndrome, you must maintain it between 2.5 and 3.5 is a value at which you need to maintain the INR, is the golden dictum which you should not basically forget. So yes, warfarin was not in options. Good, it should not be also. How can two things are possible in the same situation? Yes, what was there? Ibuprofen was there. then we are happy. Then low molecular weight heparin undoubtedly becomes the king of the forest. Let's go to the next question.